Thanks, Amit, for the kind introduction. I'm happy, and I would thank Zydus for providing me the platform and at the right time of Prostate Cancer Awareness Month. So every month we dedicate to each site of cancer, and November is a Prostate Cancer Awareness Month. So I understand that the audience are not hardcore oncologists. We have paramedical, we have even general population. There may be some patients and the relatives. So I would confine my talk not into the depth of the molecular pathology or absolute clinical trial results. I will just share my understanding and view and how up to how much we have come in treating prostate cancer. Well, if you look into the word cancer, we all are worried because even today, cancer is still considered as a deadly disease because we cannot cure almost all the patients of. I mean, we cannot cure all the patients with cancer, but as per literature, what it says, out of three, two patients with cancer can be cured or they can have a long-term disease control. So so cancer is not deadly in at least out of three of them. In out of the two of them, will have a cure for cancer. So the prostate cancer is unique in its own way. So if I look into the other cancers, prostate cancer belongs to a sort of a good variety of cancer. And the reason why I say is if I have cancer of any organ which is not vital or which is not required for survival, those cancers will have a good prognosis. For example, breast cancer, prostate cancer, uh, these cancers basically are not from the vital organs. In contrast to a lung cancer or a brain tumor or a liver cancer, which are vital organs. So, when the cancer affects vital organs, the survival comes down very sharply. So, we can, an individual can stay without a breast, an individual can stay without a prostate for his normal survival and functioning. And that's the reason why these cancers are, of course, deadly. But if you can pick them up early and treat them with proper surgery or radical radiotherapy, we can cure many of them. This is in contrast to other cancers like lung cancer or liver cancer, where the window of opportunity to save the vital organ is less. So, whenever there is a cancer, I always look into whether this cancer is originating in the vital organ or it is not originating in the vital organ. Vital organ is the organ is required for the survival of an individual. So you can go to the next slide. That looks good. So coming to prostate cancer. So prostate is basically an organ that is confined to males, and it's present right from the birth. Its actual growth happens from puberty, from around 14 years, and this is purely a hormone related growth, just the way we have the breast growing in a lady when she attains puberty, and which is again hormone related. Similarly, the prostate also gets its function of it starts its growth, and the growth is totally hormone dependent, and the male hormone is basically testosterone. So here we have an organ whose growth is hormone dependent, and the organ is not vital. So a male can survive without a prostate and can have a normal life, and the growth of this organ is testosterone driven. So the main function of prostate is to add fluid and nutrition to the seminal fluid and the semen, and help in mobility and survival of the sperms. So this is the basic function of the prostate gland. So normally the prostate gland starts growing from the puberty, and it and the growth is totally testosterone driven. And as the time goes on, the prostate gland goes on growing as the person ages. But when the a person ages at around about 60 years, it grows so much so that it starts obstructing the urinary outflow pathway. So, like the prostate's location basically is in the urinary outflow, just below the bladder. So, when the prostate grows so much so that it obstructs the urine outflow, then these men usually come with symptoms of difficulty in urination. So we all would have seen our elderly, we have seen our grandfather, we would have seen our father who are quite old, about 65, nearing to 70. They complain of urinary difficulties. Or the urinary difficulties are like they cannot hold, or once they get a feeling, they will not be able to control it, or they want to keep going to the toilet again and again. So these symptoms, what we call as hesitancy, urgency, precipitancy, this is the names which we give for these symptoms. So if an elderly male has such symptoms, then we must think of a urinary outflow tract obstruction, and prostate is the main culprit over here. So whenever an elderly male comes to you with these symptoms, we must always think of prostate being the major culprit. So not all patients who present with these urinary outflow obstruction symptoms have prostate cancer. Uh, so if you look into the prostate, it has a central zone that is surrounding the urethra and a peripheral zone that is in the outward. So the central zone growth is mainly benign, what we popularly call as benign prostatic hyperplasia, which is not cancer. It is just a enlargement of prostate gland, which is benign. Whereas the peripheral zone, when it multiplies, it's mainly a malignant proliferation, or which is cancer. A benign tumor doesn't spread elsewhere, whereas a malignant tumor spreads, it gets into blood and it starts spreading. So, what we can note from the location is a benign tumor will present to you early in the stage of disease because of its mere location. It is located centrally near the urethra. So a benign prostatic hyperplasia comes to you with a early urinary symptom, whereas a prostatic cancer, which is there in the periphery of, or it is far away from the urethra, by the time they come with urinary symptoms, they're quite advanced. So, that is the difference between a benign prostatic hyperplasia and a malignant prostate or a prostatic cancer. So the prostate cancer is different from other cancers in that what we say is above the age of 75 to 80 years, 1 in 3 men may have some prostate cancer. So that means that if there is some cancerous transformation in the prostate gland, it is not necessary that they will have problems. That is, an individual in their elderly age may have a prostate cancer, but still he may be asymptomatic, has no symptoms at all, and he may die even before the prostate cancer manifests itself. So prostate cancer is not a deadly disease in every individual. It is deadly only when it is symptomatic, or it has some hematogenous spread. So what we can understand from this is, if any individual who is elderly has these urinary symptoms, we should not ignore them. It is benign in majority of cases, but we need to rule out the possibility of cancer. So we have a elderly population, especially grandfather or father having these symptoms. This should alarm us for having a prostatic cancer, and we must get them checked. So how do I basically diagnose a prostate cancer? Because I said you that benign prostatic hyperplasia is also more commoner than a cancer. So the best way to diagnose it is what we call as the digital rectal examination. So we can feel the prostate directly from our fingers. If we can get through the anal canal and then the rectum, if I feel anteriorly, normally I feel the lobes of the prostate which are rubbery and well defined. Whereas if I find a very hard mass or irregular mass which is not moving, and the mucosa is fixed, then I can say that it is probably a malignant growth or a cancerous growth. So this is what we call as a digital rectal examination, which is extremely important clinically to find out is it a benign prostate or a malignant prostate. Also, we do what is called as a prostate specific antigen. So there is something called tumor markers, like we can do a blood test and we can say the amount or how bad the cancer is. So prostate specific antigen is one of such hormones, one of that biomarker, or uh, from the blood test we can just quantify or we can risk stratify whether it is low risk or a high risk prostate cancer. So normally we want the PSA to be less than 2, but as the age increases, PSA also increases. It can go up to 4. But if I have a PSA which is above 4, it's quite alarming. So it is not just a single value. It is the serial monitoring of values, whether it is increasing over a period of time or not, that matters. So one more thing, what I would like to say is the way the prostate cancer spreads. It doesn't spread to liver, lung, brain the way a majority of cancers do. This basically spreads to the bones, that is the vertebral bones or the axial bones. This is because of its unique blood supply, what we call as the Batson plexus. Those blood vessels that supply the prostate have a direct connection with the blood supply of the vertebrae. Therefore, the prostate cancer has a great tendency to go to the bone and deposit over there. So if you have an elderly man, whoever it is, who comes with lower urinary symptoms of difficulty in urination, and if he has a back pain, we must have a high degree of suspicion of a prostate cancer. So the way we confirm it, or we clinically assess it by a digital rectal examination to find out what is the consistency of the prostate, whether it is firm, whether it is hard, whether the mucosa is mobile. And I will do a PSA, whether it is more than 4 or whether it is more than 10. So this will roughly give me whether this is basically a prostate cancer or not clinically, even before doing a biopsy. There are other ways of understanding whether it is a cancer or not by doing what we call as the multiparametric MRI. So MRI is a very good investigation. It has certain criteria with different parameters. We can roughly say this is basically a prostate cancer or a benign proliferation. So I always suspect when a male comes with urinary symptoms, bone pain, or especially the back pain, I do a digital rectal examination, I do a PSA level, and I do a multiparametric MRI if it's suspicious. And the way to confirm is by biopsy. For the biopsy, you do not have to take him to the operation theater and open the prostate. Instead, we can do in a very non-invasive way by what we call as TRUS, transrectal ultrasonography biopsy. We take chunks of tissues from multiple sites from all the lobes, and we will label them, and that is the way. And in the biopsy, we will get whether it is a cancer or not, which is usually an adenocarcinoma. So from biopsy, we confirm that it is cancer. Not only we confirm it is cancer, we can also understand whether it is a low risk disease or a high risk disease, depending on how much fast it is proliferating. And we have put a score, what we call as the Gleason score, or the GS. So if you have a Gleason score of 6, we call it as 3+3, the histological classification. It's sort of a good sort of a cancer. It is not multiplying fast. If I have around 7 and 8, 7 is again intermediate, and the moment it is 8 and 9, it's fastly proliferating. So depending on whether it is 6, which is low risk, 7 and 8, 7 is an intermediate risk, and 8 and 9 is a high risk. So the Gleason score will help me understand how fast this prostate cancer is multiplying. So I can have two. So with this, I can have two different individuals. One individual in the non-metastatic setting, when before the prostate cancer has spread beyond the prostate. I can have two individuals. One individual is where I have the patient presents with lower urinary symptoms, and I have a PSA of around 5, and I have a prostate that is not spread beyond the prostate. It is confined with it is not invading the bladder. There is no lymph node involvement, and the biopsy is Gleason 6. So this is a low risk disease where the PSA is low, the T size or the spread of the tumor is not beyond the prostate, it is confined to the prostate, and the biopsy shows it's a low grade or a Gleason 6. So this is a good risk disease. In contrast, we have what we call as a high risk disease where I have a huge prostate that is going into the bladder, and even it is going on to the pelvic wall, and we have a high PSA of about 20, and the Gleason is saying it is 9. So by these three factors of the PSA levels, the Gleason score, and the tumor size, we can definitely say whether it is a low risk disease or a high risk disease. So we can classify a particular prostate cancer into a low risk or a high risk disease. So if it's a low risk disease, what is important is that there is always an option of surveillance. That is, if you have a very low tumor burden or a low risk disease where it is not multiplying, it has not spread beyond, not that this prostate cancer will be mortal to the individual. So on this occasion, it is reasonable that I don't do anything. I just ask the patient to come under follow-up with serial PSA levels and examination. So this is one of the cancers where I can find out that yes, you have a cancer, but I'll be reassuring the patient that this is a very low risk cancer and this may not be harmful at all. So maybe you can be under serial follow-up with PSA levels, and if you're normal, then it may be possible that there is nothing that we have to do for your prostate cancer. So this is a different cancer. We don't offer surveillance. That is, I found a cancer, but I don't do anything. I just observe and I keep calling him periodically. So this doesn't happen with majority of cancers. For example, in a lung cancer or a pancreatic cancer, I don't have the courage to even say of surveillance. Whereas if I take the prostate cancer, which is not lethal, we have that small subgroup of patients where the patient has a cancer, but it is so low, the risk is so low that the patient may not require any treatment at all. So we need to identify this small subgroup of patients and spare them from treatment, because the treatment has its own side effects. So when we are operating the prostate gland, so we injure certain nerves, so it has some urinary problems that happen, or even what we call as retrograde ejaculation, and all these problems do happen, or the erectile dysfunction. So these problems, what we see with a prostatic surgery. So even though we have what we call as a robotic surgery, so these complications do happen. So whereas if you have the other patient where we had a high risk patient where he had the tumor that is so big, the PSA is so high, and the Gleason's is high, but it is not spread beyond the prostate. So in these occasions, we call it as high risk localized disease. So here we cannot operate them, but we treat them with what we call as radiotherapy. And nowadays we have what is called as the intensity modulated radiotherapy. So if I have a low risk disease, I can have an option of observation, not doing anything what we call as surveillance. And the second option is I can have a robotic surgery and get the patient treated. And thirdly, if it is not operable, it is quite big, then it is difficult to get a proper margin. Then it is wise to give what is called as radical intensity modulated radiotherapy. So we can get rid of prostate cancer if it is not spread beyond the prostate. So then coming on to the metastatic disease of the stage 4 prostate cancer. So the moment we say stage 4 cancer, we always say the days are numbered. So this is not the case with all stage 4 cancers nowadays. Even lung cancer stage 4, we are seeing nearly 30% of patients surviving 5 years with the advent of immunotherapy. So we used to say stage 4 cancer is a dying diagnosis where the patient will not be alive for more than 3 or 4 months. But nowadays we are seeing cancers like even lung cancer with effective immunotherapy and targeted therapies. The patients are living beyond 5 years. So we had never even thought that a 5-year survival in a lung cancer is ever possible. But now with targeted and immunotherapies, we are seeing nearly 30% of patients surviving 5 years, and that is really staggering. So then coming on to prostate cancer, it's much easier to treat a prostate cancer than a pancreatic or a lung cancer because the origin is not from the vital organ, and it usually spreads to bone. It usually doesn't involve the liver or brain. So the involvement is mainly in the bone. So the moment bone involvement is there, then the patient has bone pains. So what becomes important is the quality of life with a painless life. So what I would, the most unique thing of prostate cancer, even if it is stage 4, is that it is hormone mediated. So the multiplication of prostate cancer cells is due to testosterone. So I always have this advantage of testosterone in my hand. So if a metastatic prostate cancer comes to me, the first step I would like to do is lower the testosterone levels with whatever modality I use. So prostate cancer basically is testosterone driven. So what I would like to do is I want the testosterone to come to the lowest levels, what we call as castrate levels. So the main testosterone secretion is from the testes. So the best way to handle this is to surgically remove both the testes. So, so we usually see the 70-year-old man coming with extensive bone pains, not able to move, stretcher bound, has a cord compression where both his limbs are paralyzed, and he's not able to urinate because of the huge prostate that is over there. Just remove both the testes, what we call a surgical orchidectomy. So within 6 hours, the pain vanishes, the testosterone comes down to castrate levels, the pain vanishes, the patient becomes free of urinary symptoms. So what we say is it's a sort of a magical or a dramatic response. Like in a hypoglycemia patient, we give glucose and the patient becomes conscious. In such a dramatic fashion, where if we have a metastatic prostate cancer, if I get the testosterone levels below the range, below 20, what we say, with whatever modality, whether I do orchidectomy by removing both the testes, or I make the testes not to secrete testosterone, what we call as medical castration. So we can do it by injections, by both the analogs and the antagonists, where we can stop synthesis of testosterone from the testes. So this will cause what is called as medical castration. Even without surgically removing both the testes, we can make the testes not to work by injections, what we call as medical castration. So the most important treatment in metastatic prostate cancer is not any fancy molecule, and it is castration, whether it is surgical or medical. So the patient should have testosterone levels less than 20 or less than 50, whatever you say. So the moment a patient has a metastatic prostate cancer, the first thing what we want to do is get the testosterone below normal. And this itself will give the maximum benefit. Okay. So is that the only way to handle a metastatic prostate cancer? So previously, if I had to talk to you 5 years before, I would have said, yes, get the testosterone levels to castrate levels, and then we will see when it increases in future. We will add some active chemotherapy or hormonal tablets. But in the present era, so in addition to getting the testosterone levels below castrate levels, I have to add something else to it. Whether I can add a hormonal therapy or I can add chemotherapy. So if I have a prostate cancer, out of 100 prostate cancer cells, I can say around 80 to 85% of them are testosterone sensitive. The rest 15% of them are not sensitive to testosterone depletion, what we call as testosterone resistant or androgen resistant cells. So how will I deal with it? I can deal with it by chemotherapy. So the chemotherapy, what we use is docetaxel in the hormone sensitive setting. So if I'm using castration plus some chemotherapy to handle these androgen insensitive cells, 15% or 10% what we call, so this improves the survival of the patient. So it is not enough if I get the testosterone to below castrate levels. I also have to add some systemic therapy. So, uh, so one is castration, another one is chemotherapy. So along with this, we also have what is called as hormonal therapies. So in a metastatic prostate cancer, which is testosterone driven, if I remove both the testes, still there are some androgens in the blood, and these androgens come from what we call as the adrenals. These are the glands that are present just above the kidney. So we have a drug called abiraterone where it basically prevents synthesis of these androgenic hormones from the adrenals. So this is what is abiraterone does. We can use it either in the sensitive setting or in the resist setting later. But so we have, this is one more, and one more what we say nowadays is enzalutamide is basically a receptor blocker at the site of target. So it is an androgen receptor blocker. So whether you use castration, whether you use abiraterone, whether you use enzalutamide, all these three are just handling these androgen sensitive population only. So if I have a patient with a high prostate, it makes sense for a high PSA, it makes sense for me to use this anti-androgen molecules, especially castration, enzalutamide, or abiraterone. So I don't. I not only prevent the secretion of testosterone from the testes, I will also deplete the testosterone from that is synthesized from the adrenals, and I will also prevent the action of testosterone at its target by using androgen receptor blockers, what we call as enzalutamide. So this is the treatment modalities we have. So any prostate cancer, for that example, a metastatic disease, it will have an initial phase of androgen sensitive phase, where I can give castration or get the testosterone below normal. It is sensitive, but after a period of time, the androgen resistant population will pop up. What I was saying, the 10-15% cells which are androgen resistant will pop up. So the moment they pop up, we call it as castrate resistant. Castration resistant doesn't mean testosterone resistant or androgen resistant, because the androgen comes still from the adrenals. I can prevent the synthesis of these androgenic hormones from the adrenals, and this prevention we take from abiraterone and enzalutamide. So along with these treatment modalities, we also have now novel therapies. So what we call as the PARP inhibitors. So there is a mutation called BRCA mutation or BRCA mutation. So normally in a normal cell, whenever there is DNA damage, so the DNA damage is repaired. So what happens in a BRCA mutation is when the DNA is damaged, the repair is not proper. Plus, these defective DNAs, the cells which have defective DNAs, where the unrepaired DNAs will keep multiplying. So that causes cancer. So a defective DNA should be repaired, or it should be completely excised and replaced by a normal DNA. But what happens in a BRCA mutation is there is a DNA damage, but the body doesn't have the ability to completely repair. It does some partial repair, some patch up. So these partially repaired cells will start multiplying, and this causes cancer and a BRCA mutation. So if I can inhibit this partial repair also by using PARP inhibitors like olaparib, what we have. So this is another way of treating prostate cancer nowadays, even though the percentage is so less. So we have PARP inhibitors. So the other one, what we say is the MSI or the immunotherapy, where in those patients where the microsatellite instability is high, we can have immunotherapy in place. But again, the number of patients eligible for this is not that high. So along with these, we also have to remember, because the prostate cancer spreads basically to the bones, so maintaining bone health is of extreme importance. So we do it by either the bone remodeling agents like zoldonic acid, or what we call as bisphosphonates, and we also have agents like denosumab. So this is another armory. So apart from this, we also have certain targeted treatments, what we call as radium therapy, or strontium therapy, or lutetium therapy. So these are also helpful in reducing the pain and also improving survival. So this is all what we have in the treatment of prostate cancer. So if I have to put an approximate number, how long a metastatic prostate cancer patient is going to survive, the initial 1.5 to 2 years is basically the androgen sensitive phase, where just by taking out both the testes, either medically or surgically, the patient will live without symptoms for 1.5 to 2 years. After that, the prostate cancer is going to increase. So then they enter into what is called the castrate resistant phase, and there he will make around 1 to 1.5 years. So if you ask me what is the average survival of a metastatic prostate cancer, with whatever best treatments I have, I can put a figure of around 3.5, 4.5 years. So this is the average survival that we are offering for these prostate cancer patients. So the way I improve survival, the best way to treat prostate cancer is, number one, be alert of these alarming symptoms of difficulty in urination, back pain. So go to the doctor early for the digital rectal examination, PSA levels, biopsy, MRI. So if it is localized, get it operated, or take what is called intensity modulated radiotherapy if it is spread beyond. So don't be hopeless. We have a lot of treatment. So the most important treatment for a stage 4 or a metastatic prostate cancer is testosterone depletion by whether medical or a surgical castration, and add some hormonal agents like abiraterone and enzalutamide. And we also have chemotherapy like docetaxel and cabazitaxel, which tackles the androgen insensitive population. And nowadays we have growing evidence for using PARP inhibitors, which is olaparib, and pembrolizumab coming in part of immunotherapy in the patients who are MSI high. So the most important is tackling the psychological aspects of these prostate cancer patients, because the moment you use androgen deprivation, so testosterone is required for the normal mood, skeletal health of an individual. So we can see a lot of prostate cancer patients where we get the testosterone levels below normal, they have a low mood, they go into depression, they become weak, they have a lot of fatigue. So it is very important to have counseling with these patients, strengthen them. Very important is keep them active. We always say that a deceased patient should not walk, you should be in the bed. But if you want if you want them to be motivated for further therapy, we have to counsel them for more activity, because androgen deprivation therapy has its own side effects of skeletal muscle loss, weakness, low mood, depression. So we have to counsel them for being active. So not only that, we also have to ensure the compliance to follow up, so that they keep following up before the disease actually flares. And the most important thing that we have to say these patients is, don't look into the PSA values, look into yourself, how well you are, because we have so much of treatment we can offer to the patient. If we can use them in proper sequence, effectively in proper doses, we can give the maximum benefit to the patient with minimal side effects. So my take-home message for a prostate cancer is, prostate cancer is not that bad a cancer, because it doesn't happen in a vital organ, because an individual can stay without a prostate with normal living. So secondly, prostate cancer is testosterone driven. So we have this, we can use this as an advantage. And the best way to treat prostate cancer is to get the testosterone levels below normal. And thirdly, when you come across these symptoms of urinary difficulty and back pain, we must always guide our relative or whoever to get tested for cancer. Not all patients with urinary symptoms of cancer, but they may have a higher risk of developing cancer, so we need to check them out. And fourthly, if you can come early, we can completely cure them by what is called as robotic prostatectomy, or we can do a radiotherapy and get rid of it. And even if it is metastatic disease, we can treat them by using hormonal agents, castration, whether medical or surgical, chemotherapy, immunotherapy, and targeted therapies like olaparib, which has come up in a big way. So most important is bone health and also psychological motivation of these elderly individuals to have an intact quality of life. So they're at the end of their life, so it is our responsibility to give them not only a long lifespan, but also to add life in whatever span which is left in their life. So, with this, I would like to conclude my talk, which is very basic and required for understanding for a common individual, than speaking of all the randomized, confused, randomized controlled trials which lead nowhere. So, with this, I would conclude and hand over back to the organizer. So, Amit, back to you. Thank you so much for your patient listening.